beta interferon into that patient, it will allow remdesivir or any antiviral to work. So a combination of beta interferon with remdesivir or whatever other IV, medication you can get, antivirals down the road, along with a monoclonal antibody neutralizing the existing virus is the key. Once you have those three interventions in early phase 2A, like you saw with Donald Trump, you're going to get cures. Absolutely no question about it. The question then comes off is of steroids. C-reactive proteins going above 20, which is the study we published out of Montefiore, showing that if once your C-reactive protein is starting to rise and it goes above 20 with the upper limit cutoff of 5, then using steroids. But the problem is, at that point of time with viral pneumonitis, you don't have reticuloendotheliitis yet. You have the early first phase of cytokine storm waiting to happen or just starting to happen. So, there are two stages of cytokine storm in the pathophysiology of this disease. That's the first phase. I don't think you need systemic steroids there. I think inhaled budesonide is probably the way to go. If you can monitor the D dimers and use the age-adjusted D dimer level, C-reactive protein, and IL-6 levels. So the cytokine storm that occurs is IL-6, IL-8, and IP-10, and alpha interferon. If you can measure the IL-6 levels on an ongoing basis, on a daily basis, and trend these markers, I think using early intervention, you're probably going to see 100% cure, which is what we are seeing. So that's one part of it. Once you go to stage 2B, with reticuloendotheliitis is occurring, and you are now starting to see macro and micro thromboembolism with D dimers 10 to 15 times above the age-adjusted normal. That's when you need full high-dose anticoagulation. Before that, prophylaxis is fine, low dose is fine. Once you get to reticuloendotheliitis, the virtuous triad, right, which we all know about, you need full anticoagulation, and the more faster you can do it, the better off you are. Then you need systemic steroids. So I think the British, when they did their discovery trial or whatever trial they called it,
Recovery
it was
trial.
done at a time of, sorry?
Recovery trial.
Recovery trial, not discovery. Yeah, recovery. I keep forgetting these names.
Hmm.
It was done at a time of ignorance. They had no idea about the pathophysiology. So they threw steroids at everybody. And then they wanted their name and fame, and they said, oh, look, we've reduced mortality. I don't want mortality reduced from 60% to 25. My mortality is already less than 1%. Why am I going to use that knowledge, which is useless to me? It's not based on any pathophysiology. This is pathophysiological knowledge. And so we are using inhaled budesonide in early stage 2A. And then in stage 2B, we are using systemic steroids for 5 to 10 days, depending on the patient's trending markers. So not just blindly giving 10 days to everybody. Because
Right.
remember, steroids are a double-edged sword. If you give steroids without antiviral, potent antivirals, you are going to end up in trouble with higher mortality, as we have seen. And so that's the key message here, is managing this disease stage-wise. So assessing the patient clinically, as Arjun mentioned, on a daily basis, putting that patient in whatever phase of disease you think they're in. And it doesn't matter if you're wrong, because you'll find out next day what the real stage is. And trending those markers and intervening multidimensionally is the way to go. It's clear to me that the mortality rate can be reduced to zero just by doing that.
Right. So I think, Dr. Arjun, that's quite clear that, as his example of President Trump, that President Trump has received everything, right? It's received interferon positive, molecular antibodies, and antivirals. So in India, it's sometimes very difficult to procure things, okay? Because initially we were, had a challenge to get, remdesivir. Now it's all available, and now this trial has come, the Solidarity trial. So what is your, is there any protocol change in your treatment part, Dr. Arjun, or it's been the same after
Not at all.
Solidarity? Yeah.
Not at all. I think what after this whole COVID fiasco, I think WHO is one body. I am not a big fan of Donald Trump, but I think this is one body which we really need to look with suspicion. What do they want to tell us? We have nothing else in hand right now, and whatever we have, we've now had our fair share of patients with remdesivir, and we have that era of where we have treated severe COVID without remdesivir, and now that we have treated patients in the ICU with remdesivir, whether it is with remdesivir or with tocilizumab, this is one disease where where journals like NEJM and people like Lancet have really screwed up, and they have issued apologies. So I am not listening to any of these goras coming and telling me that this is not working and this is not working. I am going to follow what I feel is working. I have had close to now 1,500 patients in my ICU. And in the correct patients, I think tocilizumab does wonders. I'm not advocating it for everyone. I have said very categorically in the appropriate patients. Similarly, I root for remdesivir. We have had patients now, in the pre-remdesivir era and in the post-remdesivir era, and I think it makes a difference. And if big people like NEJM and Lancet can make mistakes, we are allowed to make our own mistakes and learn by burning our hands. And I'm not listening to any of these people right now. I don't trust the WHO or the Lancet or the NEJM. I think it's very sad, as sir has very correctly put, that mixing politics and mixing business interests with science is not the way to do it. So right now I am trusting my gut feeling. You might call me whatever, but I think it makes all the sense, and my practice is not going to change unless you give me a better antiviral. Until that time, I am going to use remdesivir. I am going to use tocilizumab in whatever I can offer these patients. I'm going to do.
So Pankaj, can I add to that?
Yeah, sure.
So, in deference to Ninja, I think WHO proved one very big thing, that a large scale trial can be done in 30 countries outside of the developed world. And I think that is phenomenal. So the Solidarity trial is a phenomenal trial, the results of which are absolutely useless because, as I said, remdesivir alone doesn't work. So I'm going to discount the results, except I'm proud that people like Ninja who are working for WHO are doing this for the first time. And I think the value of this going forward is absolutely immense. So let's not just totally throw that trial out. So that's one thing. Two, I think tocilizumab, as Arjun mentioned, has to be given at the right time. There are two phases of cytokine storm: early viral pneumonitis phase and then the reticular endotheliitis phase. So phase 2A and phase 2B. That's where you have to time it right. If you don't give tocilizumab at the right time, you are not going to have any effect. Tocilizumab only buys you 48 hours for the antiviral and neutralizing antibodies to work and for the immune system to work. But I think those 2 days, both in phase 2A and phase 2B, that's why we give 2 doses sometimes, those 4 days could be critical, life-saving for that patient. And I'm certain, because we've reduced mortality to 0 by using it. But we are moving away from tocilizumab. We are moving towards JAK1, JAK2 inhibition in phase 2A. Only people who go through phase 2A, where we start to see the C-reactive proteins go up and the D dimers go up, we institute JAK1, JAK2 inhibition because that sort of ablates the cytokine storm from occurring in the first place. So we are not being reactive, we are being proactive. So I just wanted to add those 2 cents.
Right. I think the one question in the chat box, it was quite clear that, patients having room saturation, maintaining room, that room air, and having a patch in the X-rays. So it's quite clear that patient has to be admitted. There's no home isolation for them. It is without hypoxemia. It is stage 2, already in stage 2A actually. The patient has to be hospitalized. There's no role of home isolation in a particular patient. That I think the answer is very clear. So Dr. Vijay sir has some questions. So I asked Dr. Vijay President sir to unmute and ask Dr. Harish if there is a question. Dr. Vijay sir.
Hello.
Sir. So audible, sir.
Yeah. My question is, any role in the prediction of outcome in patients of severe or critically ill patients? The ratio of IL-6 or IL-10?
Ratio of IL-6 and IL-10. Dr. Harish, you want to answer?
Yeah.
Dr. Harish, you unmute yourself.
Yeah, so I think that's a great question. I love the image, by the way, Vijay. This is a great image of the mask. I should be wearing a mask. But anyway, so I think the ratio of IL-6, IL-10 is being looked at very, very carefully right now. Several studies going on looking at these ratios, these levels in real time and their ratios and the prognostication and the intervention that will follow. What intervention do you do when you have a very super high IL-6 level and a IP-10 level, which is high, but the IL-10 level is low, and what does that mean? And should you intervene with high-dose systemic steroids at that time, or should you intervene, later on? All of those things, those answers, I don't have. I'm just broadly seeing IL-6 levels go up and using anti-cytokine, whatever therapy, whether you want to use tocilizumab, you want to use JAK inhibition, you want to use steroids, or a combination of those. But I think that's a great question, and we should have answers to that in the next 2 to 3 months.
Yeah, Dr.
So
Arjun, you want
I
to say
just,
something?
yeah, I
Yeah.
just add a point to that. So this ratio of IL-6 to IL-10 has been in vogue for sepsis for a very long period of time. There have been pharma companies, which have come up with anti-IL-10 inhibitors which specifically, inhibit more of IL-10. So we were actually waiting for this ratio to come up with COVID also, because this IL-6 IL-10 ratio has failed big time in sepsis. Per se, this IL-6 IL-10 used to be something that when we were in MD, this used to be a very hot topic, but then it fell out, because there were really no takers of it. I think this ratio is like something like vitamin D. If you find, there are trials of vitamin D from sepsis to trauma to,
Everything.
suicide to everything. So you will find IL-6 to IL-10 ratio in abdominal injury to road traffic accident to sepsis, and everywhere this ratio has failed miserably. In fact, a few days ago on our Saptajang group, we were discussing कि अभी तक IL-6 IL-10 वाला नहीं आया, and it has now come in. So it was bound to come. It will be there, and there would be something, some intervention would come for this also. And then, like sepsis, I think it is going to meet its fate, but then only time would tell. But yes, people are studying it like for every other disease, and we'll have something on it very soon.
Right. Yeah. So, Dr. Arjun, this regarding the TOSI, controversy, TOSI, who have, dumped in the market, I would say that, issue or advisory, it's not working, and, they're taking the things out. So, and at that time, TOSI is not available at the moment. So, is there any change in that? You said that you used TOSI at a specific time. So, still you are using TOSI, or it's available at your place?
It's absolutely available, sir. Thankfully, my hospital had the sense to keep a stock of it. We are not giving it to anyone, so we still have it. And I think, sir, as Dr. Harish very rightly said, it is to be used in the right patient at the right time. You obviously are not going to use tocilizumab in someone who's been on the ventilator now for 10 days, already comes to you with fibrosis and bad infiltrates, and the lung is already hardened. It's in a patient who's in the hot phase of the disease, is in 2A, 2B, you really, the infiltrates are still soft, the inflammatory markers are high, the patient is in respiratory failure. You've proven that your IL-6 values are more than 10 times the normal limit. Only in those patients, there is more and more data coming with itolizumab and other, biological agents. But in India, one needs to use these agents very carefully, because we have a lot of patients with latent tuberculosis and other latent infections which might actually manifest in the later part of the disease, wherein and a lot of these patients are actually diabetic. So whenever you are honking up the immunosuppression to such a high level, you need to be careful. But I somehow don't understand the negative press with tocilizumab, the Roche trial, and all the negative trials coming up. I think if you look at the data in retrospect, the data is actually quite muddled up. Now, if you are studying COVID per se, and if you say that I have done a trial of, if you look at the Roche trial, for example, and you say that I have given tocilizumab to these 200 patients, and I'm now coming up at a conclusion that tocilizumab does not work. Now look at their data, go to the fine print of the data, and what you will find is that in that data, around 1/3 of the patients were not in respiratory failure. 1/3 of the patients were already in respiratory failure for the past 7 days. So 2/3 of your patients were not actually candidates for tocilizumab.
Right.
And then you say that your drug has failed. So I think one needs to really relook that. We need to look that up in the appropriate patients. It's a drug, it's a niche drug. And if you use it in the appropriate patient at the right time, it obviously would work. It would buy time. It would act, it would let your antivirals take over for that period of time. But then if you ask me, if you want to give it to every patient who's in the ICU, then that's obviously wrong practice. Yeah. We still have it in our ICU. We still have stocks of it. I'm not sharing it with anyone.
That's great. I think a question from postgraduate student, they want to learn, Dr. Harish, that when to initiate remdesivir in our patients, and what should the duration of remdesivir, 5 versus 10 days, right? So any comment on that? Yeah.
So this is now evidence, because the Gilead trials, unlike the Solidarity trial, was done in a very, very well-controlled, well-randomized double-controlled trial. And I think that's evidence. So that's the only evidence we have, any real evidence for antiviral activity. It clearly works. If you use it sooner rather than later, when the viral load is very low and the virus is just trying to multiply, it works. But it doesn't work alone. You've got to use it with a neutralizing antibody. You've got, whether it's plasma or monoclonal cocktail or whatever you use, you've got to use it with alpha interferon inhaled. And we are showing that the combination of remdesivir and alpha interferon, the data is going to get published very soon in the next month and a half, along with monoclonal antibodies, is clearly a home run. It's a home run. You take out one of those three modalities and your efficacy starts to fall, patient starts to progress. Now you can still salvage that patient down the road with appropriate intervention, but you're now starting off on the back foot. So there's no question remdesivir it's a borderline drug by itself. I understand that, but it has a key role in its antiviral activity in combination with other modalities.
So remdesivir should not be used alone. It should be in the part of the cocktail regime that actually we are getting. And rightly said, Dr. Harish, that that you have very clearly described the staging of disease. You have to stage the disease and then use drugs appropriately. And it's rightly said that there's no use of systemic steroids in stage 2A, right? And sometimes we harm the patients actually. Correct. Because every patient we admit in stage 2A, we put on IV steroids, right? So I think that budesonide, inhaled budesonide would work in that particular case stage. Stage 2B, definitely the steroids has to be there with other drugs. The message should be very clear, and we have to stage the patients appropriately. Right, Dr. Vijay Arora sir has raising his hands, and he has a question for you. Dr. Vijay Arora sir.
In the country like us, we are a poor country, can we replace tocilizumab with colchicine?
No data on this I know of. I know colchicine is mentioned as an anti-inflammatory.
IL-6,
anti-IL-6. First of all, I don't agree that India is a poor country. I'm very proud of my Indian heritage. I think India has more currency, intellectual currency, than the rest of the world combined. So I disagree with. I don't think colchicine has a role. I don't even know somebody's looked at it. I have never used it. I don't know anybody that has ever used it. So I would not touch it. I know it's mentioned in those charts, but I prefer methylprednisolone or Decadron. My personal preference is Decadron, and it's pretty cheap. It's easily available.
Right. So I think it's a very important message, take-home message that remdesivir works. Right? There's nothing like solidarity or something like that. It works, and definitely it shouldn't work alone. It should be within the cocktail of steroids and everything. So the very underpertinent question comes up, Dr. Arjun, first for you and Dr. Harish, the role of plasma therapy, because a lot of news regarding plasma works, plasma doesn't work. So what is your opinion regarding that?
If I have to sum it up, in my experience, I really don't think it works. And as Sir said, the evidence is out there. You've had FDA telling you, you've had Indian trials telling you. The ICMR thing was published only today. They came up with the final data. The ICMR data is out today that it doesn't really make that much of a difference. Yet, when I say that, it is one of the most common modalities that is used in my ICU, because if I don't use it, the attendants are going to pressurize me. The patient is going to, take the opinion from some other doctor where they are going to prescribe the, ki plasma de do, and plasma is going to work. Another big problem with plasma is that once you give it, the attendants expect miraculous results. Ki kal plasma diya tha, abhi theek kaise nahi hue? Yeah. So, this is another problem with giving plasma. So the ICMR data, thankfully, it is out today. The ICMR thing is out today. It's on their website. Anyone can go and look it up. And even the ICMR has issued a negative kind of a statement that whatever data they have, studied till now, it seems not to work. So, I think I'm going to put a printout of that in my OPD, and every patient who comes during the counseling session ki plasma arrange karna hai ki nahi karna hai, plasma le aaye ki nahi, I'll show them this ki bhaiya ye dekh lo. But saying all that, it is still one drug for which, or one modality for which, you get the maximum number of phone calls from the ICU bed. 8 ka plasma nahi arrange ho raha, attendant ladai kar rahe hain, kya karna hai? So in my personal experience, after having used it in whatever 300-400 patients, I really don't think it works. It makes any difference.
But Harish, your comments regarding plasma.
Yeah, so Arjun, you're saying the same thing that I said. For 5% benefit, you get 80% headache. Okay, that's plasma. And what is clear now over time is we've realized that plasma also needs to be studied a little more. So Mayo Clinic 35,000 patient trial showing that if the plasma is delivered at the right time with antivirals with a high neutralizing antibody titer, only then does it have some incremental benefit. So most of the plasma is collected, it is in the US, we weren't even looking at neutralizing antibody titers of these plasmas until halfway through that trial. So, again, ignorance, we didn't have the knowledge. Now we have the knowledge. It's very clear neutralizing antibody is the key. Whether you do it with plasma with a high neutralizing antibody titer, or as I think is the better way forward, a cocktail of monoclonal antibodies against two antigens of the spike protein, two separate antigens, so that the virus cannot mutate, cannot escape. And that's the Regeneron model, the double antibody cocktail with neutralizing antibody titers of 2,500. We're not talking about 6 and 10 that Mayo Clinic was talking about in the plasma. That's when you start to see the benefit. That's the miraculous recovery that Arjun was alluding to, that people expect, that we saw with Donald Trump. It is clear we have patients on the Regeneron monoclonal antibody with remdesivir and inhaled budesonide and inhaled inhaled beta interferon, who have made miraculous recoveries. 85-year-old with comorbidities, obese. And, that actually brings up the other issue is, if the patient is diabetic and obese, why is their sugar out of control? Why aren't they losing weight? This pandemic is a virus that is seeking out like a missile those people, because they have very high ACE2 receptor levels. So my advice to everybody, to all my patients, is lose your weight, man, get your diabetes under control, get your blood pressure under control, because this virus will seek you out.
Right.
Then you're in trouble. So, but good news is we have reduced mortality with neutralizing antibody titer. The key is neutralizing the virus.
Right. Okay, so coming on to the critically ill patient, the patient had desaturated, not maintaining SpO2, high flow oxygen. So the patient is moved to this ITU or the critical care units, right? What we call in the UK, US, and India. So Dr. Manish is there. Dr. Manish is a critical space specialist. Is the head, of the critical care unit at our center, Max Vaishali. Dr. Manish, what is your line of treatment of this, severe COVID patient that you receive in your, ICUs?
So whenever we receive the patient in our ICU, so most of the time the problem is like hypoxemia. So most of the patient presented with hypoxemia to the ICU, and we usually start our patient with the oxygen therapy. So we start with the target of oxygen therapy is around a saturation of around 95%. So we target around 95%, might be with nasal cannula, might be with some Venturi mask or HFNC. So nowadays we are asking our patient to like self-proning. So self-proning is a good role in like recovering the patient. So it gives time to the patient. It gives like symptomatically patient get better with self-proning. And we ask the patient to self-prone at least for 2 to 3 hours at a time, so that it has a maximum effect. And like we are using HFNC also. So even like self-proning can be possible with Venturi, HFNC, or by NIV also, non-invasive ventilation also. So these are the basic things which we are doing for our patient, like oxygen therapy. We have to see that we should give at least a good dose of enoxaparin to the patient to prevent thromboembolism. We have to continue our remdesivir. We have to give plasma therapy if patient presented within right time. So every therapy has some role when we have to give at the right time, right doses. So like in Max, we have given almost 130 plasma therapy to our patients, and we are getting good results. Basically, in our Max, we are doing antibody titers. So if we are getting the good antibody titers and we are giving the patient at the right time, so we are getting the good results. So every therapy has some positive effect, some negative effect. We have to see when we have to give the this therapy to the patient. So these are the basic things which we have to follow in the ICU.
Right. Dr. Arjun is also taking care in the ICU setting. So, Dr. Arjun, what is the management of respiratory failure? Is it respiratory failure different from patients you are getting from pulmonary indication like pneumonia with the ARDS and all that? So, is there some difference in managing such patients in critical care units, Dr. Arjun?
Absolutely, sir. So the lung involvement in COVID is different from all the other pneumonias that we've been seeing. And as Dr. Gupta has very rightly pointed out, self-proning and putting these patients in the prone position does improve their oxygenation. So whenever you're starting to treat, respiratory failure in these patients, oxygen is obviously the key. You want to maintain their saturations at above 95%. Most of these patients, when you start the treatment at the right time, you can do with low flow systems, which basically means you can do with a nasal cannula. So because there's so many postgraduates who are listening to us today, a low flow system is something wherein, you can give oxygen up to 6 liters to the patient. So a low flow system is a nasal prong. So if the patient's requirement is up to 6 liters, you can give it with a nasal prong. But if the patient's requirement is more than 6 liters, you need to give it with a high flow system. Now, a high flow system would depend on where you're working. You can either use a reservoir bag, a non-rebreathing mask with a reservoir bag, with which you can give up to 12 liters of oxygen. And if the patient is not improving, you can shift them to a high flow nasal cannula if you have that in your ICU. And then the next obvious options would be a non-invasive ventilator, an NIV, and obviously the invasive mechanical ventilator. Now, what you want to make sure in these patients is you want to delay invasive mechanical ventilation as much as possible. Putting these patients on mechanical ventilation, the outcomes are really not that good. With any kind of a viral pneumonia, whether it was H1N1 or other viral illnesses, putting these patients who have frank ARDS, putting them on, the invasive mechanical ventilation, the outcomes are going to be bad. Again, when you're putting these patients on non-invasive ventilation, you need to be very sure that your IPAPs are not very high. You're not giving them very high inspiratory pressures, because we are now seeing a lot of patients coming up with pneumomediastinums, not frank pneumothoraces, thankfully. We've had to put chest tubes only twice or thrice in the last 2 or 3 months. But we've had many patients with pneumomediastinum, especially those, wherein what is the reflex action that the patient is, you've given him pressures on a NIV, the oxygen saturation is still 85%, acha iska pressure badha do. And that is something that the ICU staff does, or the the doctor on duty would do. And when you increase the pressures in any patient where the lung compliance is bad, where there are too many infiltrates, you're going to end up rupturing the lungs. So the key here is gentle ventilation, gentle oxygenation. Most of these patients, when you start them on steroids, tocilizumab, remdesivir, or whatever anti-inflammatory, antiviral therapy that you have, most of these patients you will be able to manage on a low flow system. If you have to move to a high flow system, the best high flow system that you can use, which is the most gentle and the safest, is a non-rebreathing mask, which you can use up to 12 liters of oxygen. Otherwise, I really prefer the high flow nasal cannula. When you compare it directly to the NIV, if nothing else seems to work, now we have started using helmets in these patients. Now in India, we've been using NIV for almost every kind of respiratory failure for many years, but we were not really comfortable using the helmet. I actually thought that the helmet was not available in India, the NIV helmet. But now for the COVID, we actually, when we were getting all these pneumothoraces, and in the initial part of the COVID, where you put the patient on a NIV mask and the patient says, abhi pyas lagi hai, isko utarna hai, pani peena hai, and your ICU staff would be dead scared, ki iska mask utarenge, aerosol spread hoga. That is when we actually first looked at the NIV helmets. We searched them up. The NIV helmets are freely available. The problem is they're expensive, 22,000 to 25,000, and they're non-reusable. But we are using that quite frequently in our ICU, and it does make your life quite simple. So if you have to use the NIV, this is a practical UPP, or a usual practice point, which we have learned now after managing a lot of our patients. Try to use the NIV helmet. It's actually quite user friendly, and it's not difficult to use at all. So you can try it. But the key take-home message in NIV or in managing respiratory failure in patients with COVID is to be gentle. It's a big task. It's a horrible task putting in chest tubes in patients who have COVID and exposing yourselves. It's not a pleasant sight. So
Right.
be gentle.
Yeah. So I think we have a few papers from our respiratory department from pneumomediastinum, published in recent journals, right? So Dr. Manish, there's a few questions in chat box regarding the role of antibiotics in COVID patients and role of steroids, right? What is your preference? Like Dr. Harish said that he used Decadron, in his practice. So what is your preference regarding dexamethasone versus prednisolone, and regarding the antibiotics that we are using in our ICU centers?
So in our ICU, we are more familiar with Solmidrol. So we are using this Solmidrol in our patients, as it has a better lung penetrations. So like Dexa we can use, but we are comfortable with Solmidrol, so that's why we're using Solmidrol. And most of the patients, to prevent the secondary infections, we are using like some antibiotics, sometimes BL-BLI combinations, and azithro or doxycycline. So doxy is like nowadays more preferred in our ICUs. So it covers most of the atypical bacteria. So these are the two antibiotics which we are using in our ICUs.
You're not going for the high generation like this meropenem salt and everything.
So even like we are doing the procalcitonin and other markers, so they are not raised. So like they are not in proper sepsis. So these are only for prevention for secondary infections.
Right. So Dr. Arjun, any role of antibiotics, like what are you doing in the Yashoda ICUs?
Same, sir, same.
Same.
So doxycycline, azithromycin, not really as an antibiotic, but as a disease-modifying agent.
Right.
Yeah.
But then most of these patients would be on a third-generation cephalosporin. Most of the time, ceftriaxone. If not, combination of cefoperazone, sulbactam, and obviously you want to do their PCT levels. And if there's any evidence of sepsis, you cover them. As for H1N1, in H1N1, we always make sure that we would give them some kind of a gram-positive coverage. Now with the COVID, as of now, we don't have that data, whether these patients, every patient with COVID pneumonia who's in the ICU needs gram-positive coverage, but there is a lot of data coming up with invasive aspergillosis and COVID. So probably over the next few months, we would have more data with that. But yeah, that's what we would do.
Yeah, Dr. Manish, what is the ventilator strategy? Suppose the patient needs invasive ventilation. So is any the difference between ventilating such COVID patient, because he said that the overall prognosis is very bad. The patient gone on ventilator, the mortality is very high. So what is your experience regarding such patients in your ICU settings?
Yeah, you usually try non-invasive ventilation first. If patient doesn't sustain with non-invasive ventilatory strategies and patient require higher support of oxygen, patient is very tachypneic, like a patient is like exhausting. So then we have to intubate patient. We are not going like early intubations. So early intubation is not going to help the patient as per our experience. So whenever like patient is going to intubate, we are going to intubate the patient. So most of the patient need prolonged ventilatory strategies, and some patient might need tracheostomy, and some patient need like prolonged ICU care also. And like for ventilatory strategy, we usually follow ARDS protocols, like low tidal volume, and also not very high PEEP. So we are seeing like whenever we intubate the patient, so most of the patient has like barotrauma. So pneumomycelium, pneumothorax, these are very common things. And few patients have bilateral pneumothorax. They have spontaneous pneumothorax, not because of like any procedure. So these have spontaneous pneumothorax. And that's very troublesome to manage these patients. So BPF is going on. We have to put the like bilateral ICDs. So these are not going to survive for a long time. So we usually avoid intubation as far as possible, but definitely we have to intubate the patient at the right time. Crash intubation is not recommended right now.
Right. Arjun, your measures of ventilating such patients?
Absolutely same, sir. Low tidal volume, gentle ventilation, no crash intubations. And it's really very unpleasant to put in bilateral chest tubes and doing all that in patients with COVID. Your staff really curses you. किसी और patient में होता तो फिर भी ठीक था. इसमें ये सब क्यों करना है तुमको? And it makes a be gentle, be gentle. That's the take-home message. ARDS ventilation, low tidal volume, low PEEP ventilation.
Right. So one question has in the chat box, Dr. Harish, that the duration of steroids, right? So patient on some IV steroids, and how long you would like to give the steroids?
Yeah, so I'm going to address that. I do want to add, Arjun and Manish, we are doing surveillance cultures of the respiratory tree in case antibiotics are needed for emerging nosocomial pneumonias. We have seen a preponderance of Staph aureus pneumonia in this setting, but that may be just a local factor. So surveillance cultures help guide your therapy because you narrow down on antibiotics. You don't want to give broad spectrum like meropenem and cefoperazone for long periods of time because you're destroying the person's human microbiome. So that's one part. The duration of steroids in early disease, if the patient is recovering phase 2A or 2B, whenever you use systemic steroids, if the patient is recovering, I try to minimize the duration of steroid use to 5 days. But if the patient is severely ill and progressing and going through the various phases, then we use it for 10 days. And we generally try to avoid using 6 days, 7 days, 8 days, 9 days. So it's either 5 days or 10 days of steroids. And the dose is the same. We don't taper it off. 5 days, you don't need tapering. 10 days, some people might argue tapering is necessary. We don't. and we have not seen any trouble. I do want to get the the impressions from Manish and Arjun about aviptadil. We have used it very successfully now. So ARDS does happen. That's the final stage, right? Fibrosis and ARDS. ARDS is where you have surfactant deficiency and you have no oxygen going through the membrane. And aviptadil, which is a synthetic human vasoactive peptide, actually reverses that process and allows oxygenation to occur and allows surfactant to form. And it has made some dramatic improvements in patients. And then, of course, when all else fails, we are using ECMO. And we had a patient, one of the pulmonologists from at Mount Sinai, where my brother-in-law is the chief of critical care. He was maintained on ECMO for 45 days and then got a lung transplant, bilateral lung transplant. But that's fortunately a very rare situation. So I just wanted to throw that out there. So your thoughts, Arjun, Manish?
We've had patients on ECMO, sir, here, not in my center, but there are centers who are doing ECMO for COVID. We've had patients, 2 of our patients who've gone in for lung transplant. One patient had to be, ferried off to Chennai because Chennai and Hyderabad are the only 2 centers who are doing lung transplant in India right now. So that is being done in India. And about the other agent that you talked about, I have no clue regarding that. Never used it. So no clue.
Dr. Manish, we have just discussed about TOSI. So is TOSI used there in our ICUs, or it is a drill off from the treatment part?
No, we are using tocilizumab, but at the right time. So right time, right doses is recommended for each and every therapy. We are using tocilizumab when patient is not responding to the usual medications at the initial days, not going for after 5 or 7 days. So initial therapy is always better, and we are getting the good results. So we are still using, and the tocilizumab is available with the packs.
Right. So I think the clear, message from all the panelists regarding TOSI, regarding plasma, regarding remdesivir. There is no doubt about regarding steroids that we have covered. Now, I think Dr. Anupam has left. He'll be joining soon. Dr. Gupta, sir, you just discuss about vaccine, and we can take a few questions after
that. Thank you, Pankaj. Will you kindly share my screen?
You can share your screen, sir.
You kindly share the slide that I've given you.
Okay, right. Just wait for a minute.
Vaccine is the most fascinating part of the whole world is waiting for the vaccine. It's not the slide.
Okay, just hold on. Okay.
No, that's not the slide.
No, that's
Yeah, this is the slide.
So you can go ahead, sir.
Thank you. This is the draft landscape of the COVID-19 candidate vaccines, which has been updated on 19th of October, 2020 by the WHO. And this is a slightly congested slide, but if you see the slide, you find that most of the vaccines in the front line are the Chinese vaccines. And can we have the second slide? And this is where the American vaccines, they fall in the second in line, the Russian vaccines, and third slide, please. Third slide, please. This is the slide which I wanted to show that on the top of the corner, you find that the Sanofi Pasteur. We have grown up seeing the Pasteur issued as the prime institution giving the vaccines to the world, but here in case of COVID, they are not leading the world, and rather it is the China and the Russia and the USA and India, of course, in its own way, which have been doing things in a great way. Next, please. And this is the slide and these photographs they have been doing round in the social media. What are these vaccines? And many of the friends in the UAE have been sending these photographs in the social media. I'm just going to talk about these vaccines. And what you see on these vaccines is this is the Wuhan Institute of Biological Products, and this is the Beijing Institute of Biological Products. And you see that it is 4 microgram per 0.5 ml, and it is CNB. I'm going to talk about it, CNBG. Next slide, please. The 4 candidates in the frontline candidates, the one is the Sinovac Biotech from China. It is another inactive vaccine. And the CNBG vaccines, there are 2 candidates which are also inactive vaccines. And CanSino Biologicals, that is the state-owned company of the China, which is making AD5 and COVID vaccine, which was the frontline vaccine till 2 months back. But it had some problems. It could not produce consistent results, and the third phase 3 trials in the Canada could not start. I'm just going to talk about Sinovac Biotech and the inactivated vaccines of the Sinopharm. Next slide, please. This is the video you must have seen. Can you run this video?
It's not. No, sir, it's not. Not
it is running.
Possible.
You tap over here in the center, and it is going to run.
No, not running, sir. I've checked it. We have seen this video.
You have seen this video. This video is regarding the. Everybody has seen this video. This video is regarding the Sinovac vaccine, which is being given to the candidates in the phase 3 trials in China, and it has been produced by the BBC. Most of the people are rushing to the local hospital to get a jab, and though the vaccine is not yet proven, they are signing a document, and they are very happy having received the vaccine. And this is likely to be the scenario in another few months in India and other countries. I was just talking about the Sinovac vaccine, which is a phase 2 clinical trials. The vaccine has been tried in about 600 healthy adults aged 18 to 59 years, and 3 microgram dose is being tried. I just said that it is around 4 micrograms, but this now the phase 3 trials are being done with the 3 microgram dose, and the immunogenicity is pretty high to the level of 98%. And in about 42 days, the immunogenicity develops. The vaccine has been tried in the healthy adults of 60 to 90 years of age also. And the phase 3 trials are being done in Brazil, Turkey, Indonesia, Bangladesh, and possibly Chile also. Coming back to these CNBG Sinopharm state-owned vaccines, which you see in the social media. Next slide, please. These are 2 vaccine candidates in phase 3 trials, and they are being tried in the United Arab Emirates, Peru, Morocco, and the Beijing Institute vaccine is again being tried in the United States of United Arab Emirates, Bahrain, Jordan, and Argentina. And the September 14, the UAE gave emergency approval for the Sinopharm's vaccine. And they're the front-runner vaccine as of now, but which vaccine is finally going to sustain and survive is a matter of time. And CanSino Biologicals, the adenovirus vaccine, the adeno5 and COVID vaccine was the front-runner vaccine, as I said earlier. Next slide, please. Next slide, please. And this is regarding the Indian vaccine update. The Director General has given the approval to the phase 3 trials of the Bharat Biotech Covaxin, and it is an inactivated virus vaccine developed by the Bharat Biotech, ICMR, and IV Pune. And the phase 3 trials are likely to start in Mumbai, Delhi, Pune, and Lucknow in about 10 states, and about 28,000 subjects are likely to be involved. The Covaxin phase 1 trial started somewhere in July, and you will all remember that the ICMR letter directing the centers to speed up the trials and declare the results by 15th of August had created a lot of media furor. And recently, but the phase 2 trials have produced wonderful results, and recently enthused by the good results of the vaccine in phase 2, company had cut short the number of participants in phase 2 from 700 to 350 and moving ahead to the phase 3 trials. And no vaccination program is possible without the Serum Institute of India. And Serum Institute of India has yesterday only declared that it plans to produce 1 billion doses of vaccine. And they plan to roll out one vaccine every quarter in 2021. And various vaccines that they are going to manufacture is the Covishield, Covovax, Covivac, and SI Covax vaccine. Covishield is the Oxford University vaccine, and they have been producing around 20 to 30 million doses per month. And they have been deliberately keeping their capacity low to manufacture this vaccine because of the uncertainty, though they have a capacity to produce around 60 to 70 million doses per month. And they are going to release this vaccine in the first quarter of 2021. And the Serum Institute of India COE, Mr. Radar Poonawala, had already said whatever vaccine is produced for the world, 50% they are going to reserve it for the India. And the cost of the Covishield vaccine has been pegged at rupees 1,000 per dose for the Indians. And the second coronavirus vaccine is the Covovax, which has been produced by the Novavax company of USA, and it is undergoing trials. It is undergoing trials in the Australia, and it is likely to undergo phase 3 trials soon.
Yes, I'm muting them. Some noise, I muted it. Okay.
So we are likely to have a vaccine as of now. Another important update is that no vaccine is being tried from the nasal route, though the Bharat Biotech vaccine and the Novavax vaccine have the potential to be used intranasally, but as of now, the trials are being done intramuscular route only.
Right. I think this is a very important information. Indian government has actually started the registry also to get vaccines, at $2 vaccine a dose for the healthcare workers. And I think they have started in state-wise registry of healthcare workers. And they are going to complete soon. But Harish, what is the state of vaccination in US right now, sir?
Yeah, so thanks. This is great, Satish. So in the US, we have 5 vaccines that we are looking at very carefully. The first one being the AstraZeneca Oxford vaccine, which you presented. And the data there is sort of marginal, I think, at best. My reading of the literature, I can show you the trials and the data, the phase 3 data that is currently available to me from a week ago. And it looks marginal. And there are issues with an adenovirus vaccine with transverse myelitis and Guillain-Barré syndrome. So a lot of people are, being a little edgy about getting an adenovirus vaccine, especially an adenovirus which is the same as the one that was used. So it's 2 shots, the first shot and the second shot. The Russian vaccine differs by having 2 different adenoviruses. And then you have the Moderna vaccine, the mRNA vaccine, the new technology, which is, takes the antigen, delivers it with an mRNA, and that can be 2 types, whether the mRNA is self-propagating or is it limited propagation. The Moderna vaccine also actually is looking worse than I ever thought. It's worse than the adenovirus as far as protection is concerned. But remember, protection for vaccines, all vaccines, it's twofold. One is the cellular immunity, so neutralizing antibody. Humoral immunity, which is neutralizing antibody titer, which lasts for a certain while and then declines, and you have to either get a booster or it results in a cellular immunity, the Th1, Th2 cell responses. So what we are seeing with AstraZeneca, Oxford, and Moderna is that the cell responses are very marginal. And so I think the efficacy of these vaccines, if any, 50 or 60% protection is going to be short-lived. And so they are not the best as far as I'm concerned. The Pfizer-BioNTech mRNA model that has been used in oncology for 4 years to deliver antigens, which is now has fully enrolled, and Pfizer has applied for emergency authorization. So their data obviously looks fantastic. And I think if you're going to do an mRNA vaccine with a self-propagating mRNA, you're going to go with Pfizer-BioNTech because that technology has already been used. They know how to turn it on. They know how to turn it off. I'm oversimplifying it, but it's important. And so now if you can just mute, yeah, thank you.
Right. I'll just.
Thanks, Bhagat. So those are, and then you have the J&J vaccine, as you pointed out, which is the 2 different adenoviruses, adenovirus 1 and adenovirus 5. And so you have a much better booster response because the adenovirus is different as the vector. And so that J&J vaccine is also looking very good, although it was just put on hold because one patient who got the adenovirus vaccine died of coronary artery disease. And so that is undergoing DSMB review. The vaccine that you didn't talk about, which is my favorite, personal favorite, is the nanoparticle Novavax vaccine. And if you think I can share this with you, the neutralizing antibody titer of that vaccine, can I do that?
Sure.
All right, let me see if I can do that. Also, you have to enable it. It says host.
Yeah, I'll just, okay. It's enabled, you can say this.
Okay. So let me bring that up. Here it is. Okay, so the nanoparticle vaccine against SARS coronavirus 2 anti-spike IgG response. This is neutralizing antibody response, which is done through the various cell models, cell structure models. And you can see the responses with the nanoparticle with a adjuvant of 63,000 neutralizing antibody titer. To me, that means this vaccine itself, so I'm going to just stop sharing this now.
Right.
Okay, good. This vaccine has durability. 63,000 is huge. I mean, you're looking at 5,000 versus 63,000. This is going to last for at least a year or two. And the higher the neutralizing antibody response, the more likelihood it is that you're going to have a Th1 and Th2 cell response, because that just correlates with the amount of antigen stimulation of the immune system. So I think the best vaccine, as far as I'm looking at in the immediate near future by February or March, is the Nanovax vaccine. And that's why that stock is just going crazy right now. All the other vaccines, I think, except for the Pfizer one, are probably marginal. Some are marginal. J&J vaccine looks good. But again, the big thing to think about is, let's say you take one of the marginal vaccines. Does that preclude you from getting the better vaccine that's going to come down 3 or 4 months down the road? And I think that's key. Imagine getting the Moderna vaccine and then realizing you can't get the Pfizer vaccine just because you've now neutralized your mRNA delivery to your immune system. So very, very important. I think this is key. And then most importantly, can the virus mutate and escape the neutralizing antibodies and the Th1, Th2 cell response? We don't know. So there are several questions that need to be answered. But this is the key to solving this pandemic, I think.
Right.
Dr. Harish, I would like to know what is your uptake on the vaccines being tried by the China, the CanSino and all these. You are not very fan of these vaccines.
I am not going to go even close to any Chinese product. Period. End of story. Don't even get me there. I mean, you have no idea what they're doing. You have no idea what their quality control is. What they've done is actually misled us during this epidemic from the beginning. The science coming out of China has been nothing but garbage. And I have just learned to discount everything and anything that's coming out of that country. End of story. And I think you try and offer Chinese vaccine to anybody in America. If even one person accepts it that's not Chinese, I'll be surprised.
But you can't have a disrespect for the virus.
Right. Okay.
They produce a wonderful virus.
Yeah.
I'm not going to go there.
Yeah. So I think there are more than 100 players there in the globally, like for the vaccines. Dr. Anupam, you are following these trials very closely, these vaccine trials. So what is take on that, vaccine development, Dr. Anupam?
The vaccine, as Sir rightly said, the vaccines, the trials, the Pfizer one, we were looking at, the EUA, it was near to the American elections, and then there was some politics around that. But I think, and then there is a recent controversy regarding the ChAdOx vaccine, transverse myelitis issue. The point here, I want to, as I said, that for vaccine, since we are going to give it to the normal individuals, it is absolutely that the trust is preserved. Because if people develop suspicion regarding a vaccine, then it is going to be a very, downstream, it can have very potential disastrous consequences. You have already seen a lot of things drugs being made into curd. You have a remdesivir curd, hydroxychloroquine curd. Now you definitely don't want that happening with vaccine when everything is pretty simple. So I think it is better, since we are giving it to normal individuals, it is better to have a proper regulatory process going on with full due course rather than rushing through it just for sake of elections or politics, which politicians are bound. That is what is happening in China. For example, China is using the vaccine. Even Russia tried giving it or to their client states like Saudi Arabia, etc. So I think we should be absolutely be clear about, giving it in a proper regulatory framework, especially in democracies.
Right. So very nice comments, Dr. Anupam. So before concluding, we have some some question chat box that we'll answer. One quick questions regarding this. Right, I'll just open the chat box. One quick question regarding this, Dr. Harish, regarding this Sputnik, this vaccine from Russia, because in India also, there mankind actually are trying to market this Sputnik in India. So what is your take on that?
So, I haven't reviewed the data on Sputnik 5 because we have the J&J equivalent of that vaccine in the US, which is being done in a very rigorous fashion. And I think if the concept of Sputnik 5 being two different adenoviruses so that the body doesn't develop an immune response against the first carrier vector and you get a healthy neutralizing antibody response to the second dose. I think it's fine if it's studied properly, as Anupam mentioned, if it's done in a proper regulatory fashion, if the quality control is excellent and ensured, and there's no politics, I think you're going to be fine. But, is it one of the vaccines I would take? I think we have better vaccines coming very shortly down the road. I'm very comfortable with preventing this virus from entering my body. And so what is the need? Someone like me who's been exposed like crazy, my exposure to COVID has been, I've been in and out of rooms with COVID patients for the last 9 months. I'm not in a hurry to get the vaccine. I'll take the best one because I think we only have one shot at this.
Yeah.
So Sputnik 5, if it's available and it provides protection and there's good data worldwide and it's easily, transported and we can bring this epidemic down at least for 6 months or 9 months, whatever the duration of protection may be, then I think it's worth it. But I will not take any of the other Chinese vaccines that Satish talked about.
Right.
Dr. Harish, I would like to know from you, somebody who is already having antibodies, like tested positive, should he be taking vaccine?
Yeah, that's a very interesting question, which leads to, reinfection. And what is the neutralizing antibody titer? How long does it last? And does that patient, after going through infection, have Th1 and Th2 healthy responses to protect and prevent? And should we be now doing seropositivity screenings to see who's eligible for vaccines? Interesting question. Don't have the answers. I can give you my gut feeling and my thought process on this. I think reinfections are clearly happening. And they're not as severe because there is some protection. What that means 6 more months down the road, because the infections we are seeing, the reinfections we've seen 4 or 5 of them now, are in patients who've been infected 4, 5, 6 months ago, and they're very mild infections. They're all been cured. What will happen a year from now? Will a lot more people get reinfected? Will this virus change? I think the thought process I have, Satish, is very simple. If the virus changes, it loses its ability to create this perfect storm. Because the perfect storm is because of its avidity to the ACE2 receptor and the dysregulation of the inflammatory cascade and the cytokine cascade. The moment this virus changes, it will not be able to do that. It's either its avidity to ACE2 receptor will be less than perfect and the body's immune system will be able to respond in a much more controlled, cohesive fashion. So I'm not one of those that believes that that someone who's had the infection, the disease and has recovered should be precluded from getting a vaccine. I think the vaccine needs to be given to everybody.
Everyone, yeah.
Whether you had the infection or not.
Thank you, Dr. Harish, for your comments and a few questions in chat box before we conclude. Dr. Arjun, there's a question for you. How to manage pulmonary fibrosis? It's very important questions nowadays.
So what is being termed as pulmonary fibrosis, we really do not know whether that is pulmonary fibrosis. Now, post-COVID changes in the lung parenchyma is probably the correct word for it, because it's not always fibrosis. What is being labeled as fibrosis, a lot of these patients, when they are given prolonged steroids and when you wait and watch, over a period of time, a lot of these shadows actually disappear. So if you ask me the exact definition of post-COVID fibrosis, whether it is radiological, it is PFT based, or so, that answer is still not clear. How to treat this post-COVID fibrosis? Well, if you look at the role of the current antifibrotics which are available, it is still not clear. There are 2 antifibrotics available in the market globally. One is pirfenidone. Pirfenidone, the exact mechanism of action is not known. What we know is that it is a free radical scavenger and it is a slowly acting drug. The dose which is given for IPF, then again, pirfenidone is approved for use not in any other ILD except IPF. And in IPF, the dose which is to be used is around 2400 mg per day. So whether the same dose is to be used in post-COVID fibrosis is still not clear. Another thing is post-COVID fibrosis or fibrosis, which is secondary to COVID, is a rapid progress. It is something which is developing over a period of 1 or 2 months or, a few weeks. Pirfenidone, by its mechanism of action, its inherent quality is a slow acting drug. So whether pirfenidone is actually going to work in a process which is so rapidly evolving is a question that every pulmonologist is asking. The other antifibrotic which is available in the market is nintedanib. Nintedanib till 2 weeks back was very expensive. It was a patent molecule of Boehringer. It was 1 month therapy in IPF used to cost around 65,000. 4 or 5 Indian companies have now launched it in the last 2 weeks. So it's no longer under the banner of Boehringer. It is now commercially available in India. It's inexpensive. It's actually cheaper than pirfenidone now, surprisingly. The one advantage in my mind of using nintedanib in patients with so-called pulmonary fibrosis is that it is a fast-acting drug. If you compare the pathophysiology of fibrosis in COVID, it is equivalent to what is seen in an acute exacerbation of IPF. Pathophysiologically, if you do biopsies of these patients, there is diffuse alveolar damage, there are fibrinous exudates, and over a period of time, these organize and there is a lot of fibrosis. And this is something that you would see in the autopsy of a patient who has had an acute exacerbation of IPF. And in acute exacerbations of IPF, nintedanib has a proven role. It seems to work. So if you ask my gut feeling between pirfenidone and nintedanib, I think nintedanib has a better chance of working in post-COVID fibrosis. The dose is 150 milligrams twice daily. The biggest problem of nintedanib is that it causes a lot of GI side effects, mostly diarrhea. So a lot of us do tend to give it with Imodium or, with the anti-motility agents to begin with. Another big problem of nintedanib is that it can precipitate bleeding. And a lot of these patients who are post-COVID are going to be on anticoagulants. So there is an inherent problem of nintedanib that it can increase bleeding tendencies. However, there's a Korean paper which has just come out, and surprisingly, they've used nintedanib in post-COVID patients who were on some kind of a, NOAC, and they've shown that it did not cause any increase in bleeding, which is contrary to what we have seen in our practice with nintedanib in patients with IPF. And we have actually encountered a lot of patients of IPF where we were giving them nintedanib and the patients actually had bleeding episodes. But if you ask me, the data as of now for antifibrotics, we seriously do not know when they are to be started. What is the exact point where an antifibrotic is to be started? We don't know. What antifibrotic is to be started as of now, nintedanib versus pirfenidone, we don't know. What dose is to be used for pirfenidone, we don't know. How long it is to be continued, we still don't know. But my gut feeling says that if you consider the pathophysiology of the disease, nintedanib would work better than pirfenidone. That is all I can, summarize.
Right. The next question for Dr. Harish. Dr. Harish, you have, categorically said you are using aspirin for 3 months in post-COVID patients. Any role of NOACs in such patients?
Any role of what?
NOACs post-COVID discharge, when you discharge your patients.
NOACs?
DOACs and newer oral anticoagulant agents.
Oh, the anticoagulations. Yes.
Yeah,
so that's an interesting, we are using D-dimer levels to guide our anticoagulation. Now, the guidelines are all over the place, depending on institution about anticoagulation. What is uniform now is based on these autopsy studies that the toxicity of extrapulmonary organs and post-COVID maladies and the aftermath of post-COVID is all related to megakaryocytes. So I think using aspirin for 3 months, 162 milligrams makes absolute sense based on that science. It's not been proven, it's not been studied. Studies are going on about that. And I think it works. I've shared with you my personal anecdotal experience. The issue of anticoagulation, so we use D-dimer levels to guide the duration of anticoagulation. Once the age-adjusted D-dimer levels come back to normal post-COVID, we stop the oral anticoagulation. So that's the short answer.
So do you combine aspirin with anticoagulants?
Absolutely. If necessary, the D-dimer levels are elevated, we do combine aspirin and anticoagulation.
All right. Okay, this question has been actually answered. Is in any comment on reinfection of COVID or COVID recovered patients and healthcare workers would need vaccine? I think that question has been already answered. Right. So another question for Dr. Arjun, how long to wait in COPD patients in COVID not improving with NIV, like for non-invasive or invasive ventilation?
Yeah, so it's not only with, whenever you use NIV, you don't wait for anything. Whether it is COVID, non-COVID, COVID with COPD, COVID with ILD, every patient who's on NIV, you need to be super cautious. If the patient is failing NIV, the patient's respiratory rate is not improving, the patient's pH is not improving, the patient seems to be tachypnic, the patient seems to be in distress, the more you prolong NIV, the more you're actually going to increase the mortality. So irrespective of the baseline respiratory disease that the patient has, you would not change your decision, based on the baseline respiratory disease. Any patient who's on NIV in the ICU warrants very strict monitoring. And if you feel clinically the patient is dipping, you probably need to a higher mode of ventilation, which unfortunately is invasive mechanical ventilation. And in COVID, it's not really all that great. So the more you can handle these patients on high flow nasal cannulas or non-breathing masks or NIV, the better it is.
Right. So on the question is remdesivir working in severe COVID, I think that question has already been answered, because nothing works in severe COVID actually, right? It's basically a host response, and patient has high inferiority markers. So only I think steroids and other, there's no role of any antivirals, right, in a patient with severe COVID. And can you be specific at which point of time that you start steroids? And that's already answered this question, because at what stage you are actually planning? This stage 2A or stage 2B. In stage 2B, definitely systemic steroids. In stage 2A, we can plan for inhaled steroids. And dexamethasone, prednisolone, choice for the institution, different from institution. Steroids prolong the period of hospitalization, ICU stay, and poor prognosis. Dr. Harish, what is your comment on that?
So steroids used appropriately with other appropriate modalities definitely improve mortality and allow you to get a patient out of the hospital. That's the long and short of it, Pankaj.
Right, great. So Dr. Paresh, you can unmute and ask a few questions you have in the chat box.
Yeah, it was a perfect deliberation today with so much of vast experience of Dr. Bhujani, Dr. Arjun, and Dr. S.K. Gupta putting all lights on vaccines. So the queries are kind of, as we all see, we know it's a viral illness. We have had viral illnesses in the past also. We know that we prescribe antivirals for many of the illnesses, in which the duration of antivirals have been decades, it has been months, it has been years. How do we decide that what antimicrobial to use for what duration? Are we as a medical fraternity, after so many millions of patients, not able to decide which antiviral, what duration? And why are we so confused that the duration of antimicrobial has to be 5 days, 7 days, 14 days, or a little longer? I mean, why are we so confused?
Paras is from MC only, sir, Dr. Harish.
For years and years, evidence-based medicine never addressed this issue of duration of antimicrobials. I'll start with that. So antifungals, antibacterials, antivirals, it was just a unilateral decision to look at 7 days, 10 days, 14 days, whatever. It was just arbitrary numbers that were picked. And then recently, over the last 4 or 5 years, a lot of data has emerged on what is the actual duration of antimicrobial therapy that's required for a specific illness. And we are starting to see that the numbers we had 6 weeks or 8 weeks for endocarditis is not true. It is organ specific, it's patient specific, it's individual specific depending on the individual's immune response and reaction. So I think this virus is teaching us a lesson. It's a virus like we've never seen before. The pathophysiology of this virus is very unique. So we are drawing on our old sort of collective wisdom in saying 5 days, 10 days. Nobody has actually looked at 6 days, 7 days, 8 days, 9 days, 10 days, 15 days. You know, what is the viral activity and viral multiplication process? We do know from crude analyses now with autopsy studies that the viral multiplication dies down after 14 days. So I don't think you need antivirals after 14 days of illness. You don't need antivirals in the first 4 or 5 days of illness. We knew that. So that narrows it down to a 10-day window. So once you have an antiviral that can penetrate into the alveolar cell, which is inflamed, and you have potent antiviral activity, I think the max you should use it is 10 days. Probably 7 days is enough, because by that time your own antibody response starts to form and the neutralizing antibodies in your own body start to manufacture. And that's what will help you get over it. Once the virus is gone, now you are left with the other inflammatory and coagulation issues, which we have become pretty good at dealing with. So that's the short answer, Paras, which is
that is what my, I think
it's
it is fair enough. That is what my point is. We have seen it so much that day 10, almost 40 to 50% of our patients are positive, right? Whether we can say that they are virions, they are not effective virus, but we have our experience that day 10, 40% plus are positive. So obviously your contention that the virus is alive for 14 days is well agreed for. And then you said first part, in initial 4 days, no antiviral should be given. I mean, I would like to contest that. Why not? If we give prophylaxis for so many of viruses, when we have post-exposure HIV prophylaxis, when we have somebody in the same family being exposed that virus, and we say that few antimicrobials are working, right? Why not give it to them? One, as a post-exposure prophylaxis. Second, anybody who is coming with a COVID positive report or having a symptom on day 1, why we as a fraternity are failing to prescribe antimicrobials when we have been using antivirals, 3 or 4 drug combination for HIV, using 2 or 3 drug combination for hepatitis B, C. What is making us so low in prescribing antimicrobial when we talk about COVID, which has done so much of dent to the mankind? I mean, why we as a fraternity do not come straight away that it is 10 to 14 days of therapy? Combining 3 or 4 antimicrobials should be a ritual till we find one single antimicrobial which is effective. I mean, why are we going so slow about all this?
So very valid questions. I think these are great questions.
No, evidence is there, Pankaj. We know that the cocktail is working. Which compound in the cocktail is working, we do not know. And we all have agreed that this is working. We all agree to 10 to 14 days of therapy. Why are we restricting it for 5 days, 7 days? Why we as a community are so broken? I mean, across the world, and we are not able to come out that, okay, 10 days should be okay. Why somebody giving 5 days? Why somebody giving 7 days? Why not we all decide that 10 to 14 days is probably okay?
I think these are very valid points, Paras. So let me address those. One is that remdesivir has significant toxicity. So you don't want to use remdesivir in everybody. It has to be given IV. We are looking at the inhaled versions. We just started that trial. And I can tell you that it's much better tolerated, but we don't have that drug available yet. What about favipiravir, hydroxychloroquine, and ivermectin? Why aren't we giving those? We have no data. We have no data that using it early on works versus waiting for a patient to become early symptomatic. Why? Because 80, 85, 90% of the time, the patient is going to recover on their own. And do you want to subject them to the toxicity of ivermectin, hydroxychloroquine, or are you going to do something to that patient by giving these chemicals that could actually be harmful? So, you know, my oath was first do no harm. And I believe in evidence-based medicine. So studies are going on. We know hydroxychloroquine prophylaxis in the dose that it was studied doesn't work. So maybe there needs to be a different dose study.
I would like to drag a little bit here. Sorry, Pankaj, allow me a little while. So I am, as a physician, seeing an OPD base, I mean the patient who contacts me on day 1, and patients, families who are exposed to a COVID positive when they are asymptomatic, to a patient when he goes into the ICU. So I am seeing the whole spectrum. I have roughly 400 patient family base who has been treated with a combination of azithromycin, doxycycline, and ivermectin. Whatsoever anecdotal data was, applied medical science to that, and they are getting 3 to 6 doses of ivermectin. Azithromycin I am using twice a day, and doxycycline I am using twice a day. I would vouch that I am using it for a little overdose. I tell the patient that I am on overdosing side, physician. that I use it for 14 days, right? Maybe somebody can use it for 10 days. Luckily, I have none of them who was initiated on OPD getting admitted, right? Almost negligible whosoever has taken these drugs for 4 to 5 days in OPD. So that obviously this data has to be presented somewhere, has to be reported. But we all have similar experiences. I am on a slightly overdosing side, and none of these drugs has significant side effects. Coming to point two, are we willing to expose those 80% who were going to be asymptomatic or recovering on their own? Yes, for 20% misery, which is being faced across the globe, we can subject the rest of the family member. Because what is India constituted of? A big families of 10 people and 2 of them getting admitted to the hospital, to the ICU, and one of them is being losing life. So if we can treat the rest of the 8 just to save life of those 2, I think that was an initial contention. Look, 80% would improve and 20% would get into a sicker illness. Once we know that we have slightly simpler regimen, and if we treat all 10 of them, we may be over treating 5 of them. 3 would be needing still some treatment and 2 would be saved. I think we need to propose it. We need to propose it to be on a higher side. I won't drag further, but I would like your comments on that.
Right.
So
look, I think, yeah, Dr. Harish.
Two aspects, okay? One, I absolutely believe your relationship with your patient is sanct. And you must do what you think is best in your patient's interest. So that's why we call this anecdotal evidence. What you're describing is your anecdotes, and I absolutely respect that. And I think that's perfectly fine. I will not interfere in that. I'm only saying that evidence is now emerging that use of antimicrobials, especially antibiotics, the long-term effects on the human microbiome, and what that does to emerging diabetes and other diseases and rheumatological diseases is becoming very clear. The sanctity of the human microbiome is now being respected more than ever before. And I think using antibiotics, even for short term, has a huge, immense damage to that human microbiome. So we must respect the human microbiome as well. Now, that's why you're a doctor. And that's why this is not just science, it's an art. You decide based on individual pros and cons how you're going to treat that individual patient and what that benefit is. From a guideline perspective, I think treating everybody without evidence is asking for trouble because we'll never be able to generate the evidence that is required. And ultimately, it is the evidence that gives us permanent solutions, right? So you're going to actually mortgage out the permanent solution by doing what the strategy that you are suggesting on a global basis. At an individual level, I have no problem with your strategy. I think it's great. Right. And you've done a fantastic job.
Right. So the last question of this panel, Dr. Arjun or Dr. Harish, can anyone take this? There's syndrome, what is it, post-long COVID syndrome, long COVID. No? Patients actually having persistent symptoms for a long time. Yeah. So how you would like to manage this with patients? So
the tale of lingering maladies. And whether it's hair loss or whether it's loss of smell, loss of taste, fatigue, whether it's heart attacks that we are seeing in 34-year-olds, or whether it's strokes that we are seeing in 50-year-olds that we never thought would happen. This is the aftermath of COVID, and I think it's reality. It's all systems involved. Most of it is platelet-derived, megakaryocyte-derived. And so antiplatelets are the way to go. I think using Ayurvedic medicine in that situation that a lot of us have read about, and some of us actually on that MAMC website are experts in. I think it's the way to go. I think meditation, I think getting the connection of your mind, body, and soul and using that to allow your body to heal and recover is the way to go. There is no allopathic cure for the aftermath. That I can tell you.
Yeah, the spiritual, spiritually connected, right? But Arjun, your comments.
So it's worse than treating the respiratory failure. It's easier to, manage the ventilator than to manage this post-COVID aches, pains, kamzori, bukhar, which is, you start tapering the steroid, the fever comes back again, the joint pains, the weakness in the legs. And, one of our best physicians is with us with post-COVID. His respiratory failure lasted only for 2 days. And now for the past 1 month, he's with us for the post-COVID fever. And we have no answer except haldi wala doodh and nariyal pani. And that's exactly what we are doing, as Dr. Harish also said. So only time would tell us, but just starting them on antiplatelet therapy, giving them NSAIDs, aspirin, if the fever is high, indomethacin, those kind of things is, it's all symptomatic what we are doing. Hopefully we have an answer to that soon.
Yeah, so I had a patient who had fever for last 2 months, post-COVID, and just had this mind and all that. But the patient, got better off, and patient is fine now. So I think with this, we thank everyone who is participating. It's already 15 past 11, and still 40 people are there. So much exhausting, and so much of having grossed discussion. And thank you, Dr. Supta sir, for moderating the session very well. And I know you're not well, you're not looking well, but still you stayed for that time. And Dr. Harish, you are wonderful, and I think we would get you on board next time also, and I would have a clap for you for an excellent,
I'm happy to help.
Yeah. And
I see Vipin is on the call. So.
We have been chasing Harish for a very long time.
Yeah. And Dr. Arjun, you are fantastic, and always, to the point, and good take-home messages. And Dr. Anupam, you are a critic analytic, and I would know to have in every platform, you always give a very clear-cut, things. And Dr. Manish, I think, has left. He has given a very clear overview of how is managed the issue. So I think most of the things have been covered, and just we've been waiting for that post solidarity and post, this controversy. The things are very clear. No WHO, no ICMR, nothing, right? What is science that you should follow, and you should get the best treatment out of it, whatever is there in this world, right? And that the clear-cut message that have been given by Dr. Harish Multani, excellent message, and definitely we are going to follow that.
Pankaj, kindly do not turn off the meeting, because we have certain old colleagues. Vipin is sitting here, right. Harish is there, Dr. Ashok Grover is there. I would like to continue for some more moments. Harish, is it okay for you?
So I'll stop recording, and I'll stop recording, and we'll.
I'm seeing Vipin after a long time. Dr. Ashok Grover, kindly turn on your video. Those who want to leave, they can off.